you everybody for joining today. I'm Elena Raffetti. I'm assistant professor at Karolinska Institute, visiting research at the University of Cambridge and the University of Uppsala, and also the deputy director of the Swedish Center for the Impact of Climate Extremes. I'm very happy on behalf of the Department of Global Public Health at Karolinska Institute and of the Swedish Center for Impact of Climate Extremes to welcome you all to this talk today. Today with me, the talk is co-moderated by Eduardo Pavoni. Please, Eduardo can introduce the first speaker, and welcome all. Thank you.
Good afternoon, everyone. Thank you so much for joining this webinar. My name is Eduardo Pavoni, and I work as a project coordinator with Elena Raffetti's team, the Department of Global Public Health, Karolinska Institute. As Elena said, we will be co-moderating this webinar today with Blanca Paniello from Barcelona and Isabel Walter from Stockholm. Yes.
So Blanca the floor is yours. Yeah, I saw that you already tried your slide. Blanca Paniello Castillo is a PhD student at IES Global Barcelona. Before she was a master student at Karolinska Institute, and she will present some quite interesting work on all Europe linked with the ERC EARLY-ADAPT project. Thank you so much, Blanca.
Thank you, Elena. And thank you everyone for being here. And yeah, as they were very much introducing, like I'm Blanca Paniello. I'm a PhD fellow here at IES Global at the Barcelona Institute for Global Health. And today I'm going to present the preliminary results of my second study as part of my PhD, which is focused on socioeconomic determinants and temperature-related mortality in Europe. So moving on. I actually always like to start with this slide. This is a diagram that represents the health risks, and we published it a couple of months ago in the Lancet Planetary Health. And here we explain a bit how health risks can be explained or can be understood. First of all, we have the climate-related hazards that we study. In my case, for instance, I'm studying temperature, but we could be studying air pollution, extreme weather events, and other hazards. But then when it comes to health risk, we also need to take into account two other components, which are exposure and vulnerability. When it comes to exposure, we're talking about the location relative to the hazard. And here we're talking about the livelihood, the built environment, the housing condition, and other factors that relate to this exposure. And then we also have vulnerability, which talks about or explains the susceptibility and the adaptive capacity of people. And here, more concrete examples are the access that people have to healthcare, their socioeconomic status, the preparedness, and the decision-making power. Therefore, when we want to understand how health risks work, we can not only have in mind these climate-related hazards, heat waves or temperature or air pollution, we also need to have in mind these other two components that when they intersect, we can very much explain them through socioeconomic determinants and other social characteristics such as class, race, sexuality, age, and other factors. Therefore, when we're studying, in my case, for instance, temperature-related mortality, having this perspective in mind and how socioeconomics play a role is crucial. So having this in mind, I will move on to the results. And basically, what we found is that there's a bit of a knowledge gap when it comes to studying and assessing socioeconomic factors in Europe in a continental-wide level. And therefore, we don't know yet when it comes to the differences that we find in temperature-related risks regarding the socioeconomic factors. There's, however, worldwide studies such as Seda et al., Serra and colleagues, that are focusing on urban and rural characteristics using also similar methodology. And there's also studies in a national level within and outside Europe in different countries and continents. But there's no study that assesses these continental-wide differences when it comes to these socioeconomic factors and temperature-related mortality. Therefore, these evidence would actually provide a working framework when it comes to studying and addressing these underlying and intersectoral inequalities within and between European countries that could be tackled in a unified way, thus targeting these vulnerable groups that we will be talking about. Therefore, the goal of my study is to explore how socioeconomic factors influence spatial differences of temperature-related mortality in Europe. A bit when it comes to the methods and how we did it. This is a cross-sectional study from the 2000s to 2019, and we use daily mortality data from the project EARLY-ADAPT and daily temperature data from ERA5LAN. We have 654 contiguous regions from 32 countries, which are the regions that you can see in the map to the right, with the annual average temperature of these regions. And we used a distributed linear model, the DLNM, using a two-stage approach in which, first of all, in the first stage, we assessed the association, the location-specific associations, and then afterwards we include these socioeconomic factors as meta-predictors, so factors that partially explain these associations. And we assess these factors by, first of all, doing a bit of a scope review of the factors that have been assessed and studied before in these national studies and the literature that I mentioned. And also the data availability in open source platforms such as Eurostat, the WHO, and other institutions. And therefore, we have factors that encompass these demographics, health systems, economics, as well as social determinants and inequalities. This is a bit of a description of all the factors that we checked and we assessed, just for you to have a bit of an idea of what we're talking about when it comes to socioeconomics and socioeconomic factors in this study. And here you can see the factors themselves, the time frame of the data that we have, the geographical level, so net 3 being the more concrete specific, and net 0 being the more national level. The source as well, and the mean and range of the values. So overall, we assessed aging, people age 80 years or over, and life expectancy. We also assessed number of physicians, hospital beds, health expenditure and financing, and then as well socioeconomic indicators in a more general way, such as GDP per capita, household income, saving rates, unemployment, education, poverty, deprivation. Then people as well owning a house, people living, the percentage of people living in cities and in rural areas, single person households, access to internet, and then these two indexes that measure inequality, the Gini index and universal health coverage. So here a bit of an overview. And first of all, what we did was to select the model. Here we used 3 indicators, the AIC, the Kaiki Information Criterion, the I-square that measures heterogeneity, and the wall test based on a p-value. And basically, we gathered different environmental factors such as temperature, relative humidity, PM 2.5, and we assessed, first of all, the correlation, and then how these indicators looked like in a model. So basically, you can see that the model 3 that includes average and annual average temperature and interquartile range, annual average relative humidity, and annual average PM 2.5 and interquartile range have significant p-values when it comes to the wall test. And then as well, when it comes to the Kaiki criteria, it's the lowest value, which give us an understanding of the model complexity, the balance of the model complexity and the fit. So therefore, we chose model 3 as the baseline model for our analysis. Then we use this baseline model, the baseline model number 3, to check single socioeconomic predictors. So we tried one by one and we checked these 3 other indicators, the I-square, the Kaiki, and the wall test, to see whether these factors needed to be or are significant and therefore partially explain this association. We did not check all the factors all together because that could lead to collinearity since some of the factors are correlated between each other. And here we basically did the same. We selected those factors that showed a significant wall test that had the lowest AIC and that had a good heterogeneity. So the ones that you find in bold are the ones that we selected, and we dropped based on these indicators 5 factors, which are saving rate, owning a house, people living in cities and rural areas, and then single person household. Then with the factors that we selected, we performed a PCA, a principal component analysis, to reduce the dimension of our data and see more or less which were the factors, the key factors driving the vulnerability. And therefore, the 4 factors that you have in the middle are the 4 factors that were driving this vulnerability based on this PCA. So we have household income, life expectancy at birth, people age 80 years old or over, and poverty, the percentage of people at risk of poverty. The maps that you have on the left, the blue is for cold, the red is for heat. These are the relative risks when it comes to mortality along Europe. And we observe that for cold, Eastern and Southern Mediterranean Europe has the highest risk when it comes to cold. And when it comes to heat, we observe very much a latitudinal pattern, with northern regions having lower relative risk to cold, and southern regions having a higher relative risk to heat. And then we have to the right, we have the privation and Gini index that I'll be explaining are actually very important factors in our results. But here you can see the distribution of these socioeconomic factors and which are the regions that have highest and lower values. For instance, when it comes to the privation, we have Eastern Europe, such as Romania, having high percentage of deprivation, of social and material deprivation. And in Gini, the Gini index inequality, we also observe how Southern and Eastern Europe has higher inequality. Having this in mind, these are the main results. You can focus first in this model 3, the first one. And basically what we did was to perform a relative risk ratio. So if you observe the graph to the left with the 2 curves, what we did was to predict what is the relative risk along temperature for the highest and the lowest socioeconomic group. So for instance, in this case, deprivation, what's the relative risk of the highest regions with deprivation and the regions with lowest deprivation? And then we extracted the relative risks for the 99th centile and the first centile, so heat and cold, and we performed the ratio to see whether there's statistically significant differences between these 2 socioeconomic groups. So you can observe the red lines are the heat-related risks, and the blue ones are the cold-related risks. So overall, what we observe are different patterns that I'm gonna explain. But you can see that we first have a forest plot for the model 3 with a single socioeconomic predictor, and then we have the other 2 that are the ones that we adjusted for those 4 factors that were driving the vulnerability based on the PCA. We checked the correlation to see that they were not correlated, and we adjusted these models for these 4 factors to see whether we could find any mediation effect. But first of all, we're going to focus in income, household income, and life expectancy together with GDP per capita. These 3 factors have a very similar pattern. You can see that regions that have higher household income, higher life expectancy, and higher GDP per capita have higher risk to heat and lower risk to cold. We can see this in the model 3 with a single socioeconomic predictor, and we can see that in the last one, when we adjusted this for life expectancy and poverty, the heat-related factors or significance got lost, is not remaining. So we can observe how life expectancy and poverty could have a mediation effect, at least when it comes to income of households and GDP per capita, since we observe that the heat-related risks lose the significance. However, for cold, yes, you can see they remain there. Then we have poverty. That poverty, in this case for cold, we observe how regions that have higher poverty have higher risk to cold. We don't observe significant differences to heat, but cold is also a very consistent result when it comes to poverty. And then, as I was telling you, the privation and inequality, that are the two maps that I showed you before, these are two factors that are consistent no matter what factors we adjust the model for. So if you observe the other two graphs with the PCA components, the results are still there. They are still significant, and we observe how regions that have higher deprivation and higher inequality have higher risk to heat and cold-related mortality, which is very much indicative of the socioeconomic inequalities we were talking about. Then afterwards, in the other factors that you can observe, we also have education and healthcare-related indicators, and we observe how cold is mainly the one that has more significance. We observe how, for instance, regions with higher education, they have lower risk to cold, but then we observe that this significance gets lost when we adjust the models for life expectancy and poverty or other factors. Then we moved on to quantify this burden. We wanted to know what number of deaths we were talking about. And we quantified the heat-related attributable numbers and the cold-related attributable numbers. The column in real, the real column, is the value for all the regions having their own value, their own Gini index value, and their own deprivation value. However, we created these two other scenarios in which we calculated the attributable number for all Europe when the Gini index the maximum Gini index would be applied to all the regions. So what would be the attributable number if all the regions had the maximum Gini index and the minimum Gini index? How would the number of deaths would change for both heat and cold? And we observed that Gini index and deprivation, the two factors that I was explaining as the most important or driving these inequalities, we observed that, for instance, for deprivation, there's a difference of 16,000 deaths between the minimum and the maximum scenario. Obviously, if we want to be talking about a more realistic scenario, we should take the real one in which all the regions have their own value, but we still observe that there's around 10,000 deaths of difference between the real scenario and a scenario with a maximum deprivation. If we move on to cold-related deaths, obviously cold kills more than heat, so we observe higher number of deaths. But when it comes to the difference between the minimum and the maximum scenario, we observe that there's around 150,000 deaths between these two scenarios, which is a big number when it comes to the potential intervention regarding deprivation in this case. So moving on to the limitations and strengths, just to do a bit of a disclaimer of what we found and our methods. Unfortunately, this study, we did not include the data, the daily mortality data during the COVID-19 pandemic period because it's still not available. However, we hypothesized that maybe because during this period there were higher inequalities as well, the vulnerability gap increased, and we could potentially see some vulnerabilities exacerbated. So it would be interesting actually to check into this period and see what happened. Also, we are studying Europe, and this is the data that we have, but we are very much aware that the Global South is also very much exposed and suffers greater vulnerabilities as well. So this is definitely a gap that we need to cover when it comes to further research. And then when it comes to strengths, as I was telling you before, this is the first continental-wide study assessing socioeconomic inequalities and determinants in temperature-related mortality in Europe. We're also using high-resolution daily mortality data from the EARLY-ADAPT project that is way more precise than weekly or monthly data. And then we're also using state-of-the-art methodology using standardized indicators from open source data that other researchers can also use. So just to sum up and conclude a bit these results, the main results that we found or the findings are that inequality-related indicators, in this case deprivation and Gini index, are associated with higher heat and cold-related mortality. Then when it comes to wealth and prosperity, that we could somehow explain by the GDP per capita, life expectancy, and household income, we found that they are associated with lower coal-related mortality. As I was telling you, there's also, we found for heat, higher risk to heat, but there's a lot of literature supporting the idea of these regions, for instance, corresponding to city areas that have, for instance, urban heat island effect and other effects that increase the heat-related mortality. Then we also observed mediation effects, which are important as well to try to explain potentially the mechanisms behind these factors. And we observed these mediation effects, how they change the results, for instance, when it comes to education or healthcare related indicators. And yeah, and overall, basically, the socioeconomic factors, what they are telling us is that they are strategic and critical venues and targets for political and policy interventions when it comes to adaptation and mitigation strategies that would lead to both to two goals. First of all, reducing the climate-related health impacts that we are observing and that we will keep observing in the future. And also as well, closing the inequality gaps and the vulnerability gaps that we're observing in Europe, but also worldwide. And yeah, I'd say that's mainly it from my side. Thank you very much. And I guess we can discuss a bit later if you have any questions.
Wonderful. Thank you so much, Blanca, for such a nice presentation. I would just wanted to ask very quickly, as someone who does not have a background in these subjects, would you like to just briefly explain what the Gini index refers to?
Yes, the Gini index is, as I was telling you, an inequality indicator. We have values for the national level, or in this case, in this study we did, and it measures it includes different indicators. It includes wealth of the country, as well as other factors that somehow impute this Gini and therefore inequality indicator. I see Stefan, maybe he also wants to jump in when it comes to this inequality part.
Hello. My question was a bit different. Thanks for the nice presentation and work. I was sort of wondering how you feel about the urban or rural context and living in a concrete suburb versus in a leafy, this and that, and if you have considered and if you have any opportunities to study the neighborhood effect, as it were, and architecture, urban planning, or what it may be, not be. Thank you.
Yeah, that's definitely a very interesting question. We've thought about it. This is the first study, let's say, like assessing these inequalities in Europe, but it's something that we could potentially do as well to disaggregate, let's say, the urban and the city level with the data that we have and potentially observe differences between these two geographical levels. There's some people doing this in the team, and it's something that we definitely need to check, because right now, more people live in cities, and therefore we need to observe as well what the dynamics are in these geographical levels. So yeah.
Great. Thank you, Blanca.
Sorry, heat and cold islands.
Yeah, exactly. And actually, when it comes to the GDP per capita, as I was telling you, GDP per capita, life expectancy, household income, that we find that the regions that have higher values of these indicators have higher heat-related risk. This is also partially explained by the fact that these regions are usually cities that have higher GDP, etc., and that potentially have these urban heat island effects and other effects that make in this case, heat-related mortality increase. So yeah, it's definitely important.
Great, fantastic. Thank you so much, Blanca. I think we can move on to our second speaker now, Isabel. Also, if anyone has some questions in the meantime, you can write them in the chat box, and then at the end of the presentation, we can go back to them and answer as many of them as possible. Isabel, thank you.
Yes, thank you, Eduardo. I'll start sharing my screen. So can you all see my screen and my pointer? I think so, right?
Yes.
Yes, Isabel,
Well,
thank
I'll
you.
hear if it's not working.
It's working.
So hi everyone. I'm Isabel and I'm a PhD student at Karolinska Institute. And today I'll be presenting to you about some of the work that we have been doing in collaboration with the University of Cambridge. And it's about air temperature and thrombotic cardiovascular disease in England, where we apply a case time series method using whole population electronic health records. So one of the main global crises of the 21st century is climate change. And its effects include an increased number of extreme weather events. We have increasing temperature variability. When we look at Europe specifically, temperatures are rising at twice the global average rate, which of course affects population health. Wait, I'm just gonna, because I can't see my full slide personally. Well, I'll just do it. It will work like this. Anyway, it affects population health, and factors such as an increased number of non-communicable diseases, an aging population, increase in urbanization, potentially render the European population more vulnerable. And what we do see is that over the past 2 decades, that heat-related mortality has increased. And there's also evidence that extreme temperatures affect other health outcomes, such as cardiorespiratory outcomes, pregnancy outcomes, or mental health outcomes. And in this all, within this all, it's very important to not forget about cold temperatures because, well, in Europe, cold spells are expected to persist with a similar intensity and frequency as has been over the past decades. And also, like Blanca actually told as well, the absolute numbers of cold-related mortality and also morbidity are higher than of heat-related mortality and morbidity. So thrombotic disease, that's like a group of diseases that is usually caused by a blood clot that occludes a vessel, and this can be arterial or it can be venous. If it's arterial, examples are myocardial infarction or a heart attack, or a stroke, and venous examples would be, for example, deep vein thrombosis. So why are we studying this? It's because thrombotic disease has a very large health burden worldwide. It's, for example, estimated that 1 in 4 deaths are caused by thrombotic disease. So there's limited epidemiological evidence on the short-term impact of, for example, air temperature on this thrombotic disease outcomes. It's interesting to study this because it is thought that outside temperature, so air temperature, could impact levels of coagulation factors in the blood and also potentially modulate the immune system, which of course could impact the formation of a thrombosis. So what we set out to do is to examine the association between air temperature and thrombotic disease outcomes, and also study related drivers of vulnerability. And we're doing that using the National Health Service England's secure data environment, which grants us secure access to multiple linked health data sets in England, covering both primary and secondary care health data. And it includes the whole English population of 58 million people. So we start off with raw data, and then we put this data through a whole data curation pipeline that includes data cleaning, data phenotyping, and all that sort of stuff. And in the end, we ended up with a cohort of adult individuals alive at the end of 2019. And then we followed them through our cohort period from the beginning of 2020 to the end of 2022. And then within this cohort, we identified our cases, because we're of course doing a case series, and we identified the cases using diagnostic ICD-10 code lists, and to the health data from these cases, we linked that to environmental data at the lower layer super output area level, which is basically it's a living area of the individuals, and this living area is about the size of about 1,500 residents on average. And then on that data, we performed our analysis. So what does this data set look like? Basically, per outcome of interest, so per thrombotic disease that we're studying, we will have one data set that includes all the cases, the occurrences of that outcome during the study period. And for each of those cases, for each of those individual, we will have daily temperature data for their entire follow-up time, and we will have indicators of whether an outcome occurred on a given day. So this is an example of what the data could look like for one. This is an example for one person. So as you can see, we have a row for each day of follow-up for that person till the end of the study period, or until they died during the study period, if that is the case. And then we have outcome indicators. So usually it will be like, there will be mainly zeros in this column, but then when an outcome occurred for that person, could be, for example, myocardial infarction, then it will be noted as a 1. And it could be that someone has multiple outcomes during the study period. And then the last column includes the daily mean temperature values. So what is this case time series? The case time series is a new method that has been developed, and it's a self-controlled method that assesses the risk of an acute outcome using time-varying exposures such as temperature data or environmental data. It uses a longitudinal exposure and outcome per individual. So this is a visual representation of the table you saw on the previous slide with an example of basically what the data looks like for example, subjects, where, for example, here what you can see, each bracket is a day of follow-up, and let's just say that this is from the beginning of the study period to the end of the study period, and then the blue dots that you can see, those are indicators that an outcome occurred for that person. This person has a shorter follow-up because they died before the end of study follow-up. And then the exposure data is added to it. For us, it's continuous because it's temperature values. And then it's also important to know that to perform this case time series, we're considering a 21 lag days, which means that this is the number of days after each temperature exposure that we are considering their effects on the outcome. Which means that we are considering, we want to look at, of course, we're looking at a short-term effect of temperature, but we want to consider like an immediate effect, but also a more subacute effect, like a bit longer, like that's why we go up to 21 days. Then to model this, we're using a Poisson regression with a distributed lag nonlinear model term for temperature, which allows for nonlinearity in the association between temperature and our outcomes of interest, but also nonlinearity across the different lag days. So for example, if you have an outcome event, maybe the temperature 3 days before that outcome event has a different impact on that outcome than if you would go back further, like 20 days before that. So that's what we want to take into account. And then all the models are adjusted for seasonality. So this slide I put in, it's just an example of what a DLNM, what it can do. It's a 3D, basically, so it's a 3D plot. And what you can get out of this DLNM is risk estimates, which you can see on this axis, across a temperature range and across different lag days. So for example, what you can see here at minus 10 degrees, we can see that here there's a relatively high risk of an outcome, of a given outcome. And then we look down at the lag axis and we see that that's approximately at 1 day. So apparently if you're exposed to minus 10 degrees, then a day later you have a relatively higher risk of this outcome. And then for example, here at 30 degrees, we see that there's the highest risk is measured here, which is a very immediate effect. It's at lag day 0. So that's like immediately on the same day effect on that outcome. So this is a bit complex. And the results that I will show are a 2D version of this, which means that it's integrated over the lag dimension here. But I just wanted to show you to have a bit of an idea what's behind it, kind of. So why would you do a case time series as opposed to a regular time series? Well, it's a case series, so it's self-controlled. So for like every event day is compared to every non-event day within a person, and that allows for time. Basically, you control for time invariant confounding. So variables such as a medical history, ethnicity, or socioeconomic status that don't change over your study period time, they are controlled for by design. So you don't need to adjust for it in your model. Then it allows you to link the temperature data on a very small geographical area, which is more precision. And then we can study vulnerability at the individual level using individual variables such as, for example, such as ethnicity or medical history as well. And then lastly, we can have basically per person, we have daily temperature data such that we isolate the effect of change in our exposure in temperature on that specific person. So the outcomes that we're studying are venous thrombosis, which is a composite of venous thrombosis, pulmonary embolism, which is usually caused by a venous thrombosis, and cerebral venous thrombosis. And then our arterial outcomes, specifically, we'll be looking at acute myocardial infarction and ischemic stroke. But then we're also looking at the whole group together of all these diagnoses. So also retinal infarction, arterial dissection, and any other arterial thrombosis in the body in other areas. So let's have a look at the cohort derivation. We ended up with 42 million adult individuals in our cohort. And among those, we identified about 200,000 individuals with a venous event during the study follow-up and 530,000 individuals with arterial thrombosis, among whom we had 250,000 individuals with a myocardial infarction and 200,000 individuals with ischemic stroke. So the distribution of female versus male sex in our cohort is very balanced. Most of the individuals in our cohort are of a white ethnic group. And then lastly, and this is an important variable, deprivation index quintile, which shows like the deprivation level of a person, which is based on the area. So the same area that we link the temperature to, that area is also used to define deprivation index quintiles, where we have 1 to 5, and 1 are the people that are most deprived, 5 are the people that are least deprived, and this is also quite equally distributed, as you can see. So let's have a look at our number of cases per month that we have for each of the outcomes. So obviously arterial thrombosis has the highest number of cases per month because it's the biggest composite. And what we can see is that in general, the trends for each of these outcomes across our study period, this is the study period on the x-axis, is relatively stable. We do see a dip here for all of the outcomes in the beginning of the COVID pandemic because of disruptions of healthcare, but in general, after that, it remains relatively stable. So now I'm going to present some preliminary results, and they're preliminary because these are still results from restricted data sets, because while case time series is really, like, it has a lot of advantages, it also requires a lot of computational power, and we're still adapting to be able to use the full data set with full follow-up time per person. So the results that I'm showing now, they're on a 3-month follow-up per person with only the first event during our study period. So this is the 2D plot that I warned you about. So this is on the x-axis, we have the daily mean temperature. On the y-axis, we have the risk ratio, incidence risk ratio. And this plot is for venous thrombosis. So what we see is slightly a U-curve with an relatively increased risk at temperatures above about like 20 degrees Celsius compared to the median of 11 degrees in England. And we do also, seems to be a slightly increased risk at colder temperatures, but this is not statistically significant. So for arterial thrombosis, we don't really see an association. And also for acute myocardial infarction, the association is quite flat. Whereas for ischemic stroke, we see a slight like protective effect at colder temperatures. But what we'll focus on for the rest of this presentation is a venous thrombotic event, also because of time restrictions and because we see most effect there. So what I'm going to show next are different analyses where we stratified. We looked at subgroups. We ran the same analysis in subgroups based on certain variables. So for example, for sex, we see that actually we see a very similar association for both females and males. For age groups, where we separated the groups into above 65 and below 65, we see a very similar association with the higher risk at the higher temperatures for venous thrombosis. And then this is interesting because this is a variable comorbidities, which is a composite variable with a bunch of comorbidities in there, like COPD, asthma, diabetes, chronic kidney disease. And basically, you compare the people who've had that in their medical history at study start date compared to those who didn't. And what we see is that the association completely, almost completely disappears. And if you look at only the people who don't have this certain medical history, whereas the people that do, there we do see this increased risk at higher temperatures. Then for the deprivation index, this is in orange, we see the line for the low deprivation index, which means that these are the most deprived people. It's a bit confusing. But there we see this increased risk at higher temperatures, and also interestingly here at lower temperatures of venous thrombotic events. Whereas if we only look at the people who live in the least deprived areas, we do not see any association. Then lastly, I want to look at our stratification analysis for ethnic groups, where you can see that for people of Black and white ethnic groups, is that we see this increased risk with warmer temperatures, but we do not see this for people of Asian ethnic group. And it is important to note here that this does not include the whole population, because there's also a mixed ethnic group and a missingness group here, but those were too small to run this type of modeling in. So this is restricted to these three ethnic groups. So to conclude, temperatures above about 20 degrees in England were associated with an increased risk of venous events compared to the median temperature, regardless of sex or age group. And people of a white or Black ethnic group seem to be more vulnerable to this. And also people living in deprived areas and people with a medical history of of comorbidities. We see an attenuated impact on myocardial infarction and arterial thrombosis, and lower temperatures seem to be relatively protective of strokes. So the strengths of this study are that it's based on population-wide data. We're using novel methods, a range of outcomes, and looking at the range of temperature, not just hot temperatures, for example. Limitations are that, of course, there could be some inaccuracies in how the temperature is linked, because people might not actually be in the location that they're registered to be living in. And then, of course, one of the limitations is the computational power, but we're working on that. And then also limitations are that there might be other interesting variables to look at that we do not have in our data set, like certain individual level socioeconomic variables or housing variables, like do people have air conditioning. So next steps for me are to do this analysis on a full data set. And I would also really like to calculate attributable risk, such that we know that basically the proportion of our outcomes, what proportion of our outcomes can be attributed to heat or to cold, which I think would be really interesting measures to include. So thank you for your attention. I would like to thank the collaborators on this project, and of course also my PhD supervisors, Elena, Cecilia, Gabriele, and Angela. Thank you so much. I'll stop sharing so I can also see everyone.
Great, Isabel. Thank you so much for your presentation. I don't see any questions in the chat box, but yes, but if someone has some questions, please raise your hand. Yes, there's someone. I don't think I can see their name, but yeah, you're welcome to ask questions.
Hello, can you
Hi.
hear me, please?
Yes.
Yes.
Hi, thank you very much for your presentation. I just had a quick question. So you mentioned something about deprivation index. I wanted to know what the parameters were in computing the index. What did you consider?
Oh, so the deprivation index is based on like national statistics that prepare that index per LSOA basically, but it's based on over I think it's about like 20 different variables on education, on income in an like average income in an area, and also I think it was also like house prices in there, stuff like that. Like it's a whole bunch of variables that are combined in there, but we don't have the separate variables. We only have that index basically.
Okay, thank you very much. Follow up. So I asked because I wanted to know if you had considered maybe any urban morphological parameters because well, I suppose that your work is at a neighborhood scale, no? And like the neighborhoods are not the same. And that air temperature has a very complex relationship with the urban morphology. So I'm supposing that in an area, for example, that has more greenery, the impacts of air temperature may be different than in a very dense concrete space. Did you consider that in at all?
Yes, so that's like super interesting, and it would be really I agree that it would be really cool to have like a measure of green space, right, per area. That would but we do not have that in this data set. But what we do have is, for example, if an LSOA is urban or rural, we do have that classification, which I also stratified on. But we actually saw quite opposite results on that, where we see that this strong association with a higher risk at high temperature for venous thrombosis, that is mainly in urban, like that's in actually mainly in rural areas, which is kind of what you wouldn't expect, but that's probably because the people in rural areas are older. So that's something to explore still, I think. But it is limited to that like dichotomous variable, basically, unfortunately.
Okay, quite interesting. Thank you very much.
Thank you.
Any other question?
Maybe I can ask a question to both Isabel and Blanca, because you're looking what we can call drivers of vulnerability or drivers of risk on two different levels. Blanca is looking this at aggregated level on the country. So I would like to know what you're thinking about the pros and cons of this type of approach, also considering that you maybe have NUTS that is like geographical area, the regions of a specific country, but I can imagine that some of the indicators, for example, the Gini and the GDP, are at country level and not a specific region level. So do you think we can do better? How do you think this type of using country level, am I biased the analysis? Is towards Venol or away from Venol? And I would like to ask a question to Isabel, what she's thinking about using individual level data, using maybe system dynamics, the DLNM model that increase complexity and might also be more difficult to interpret. So, because the key takeaway point of this is that we know that hot temperature affecting human health and also cold, and cold temperature is still the big elephant in the room, and hot temperature will become a big problem in the future, but we will have a differential vulnerability and differential risk in different population, and how can to be prepared and to adapt, we also need to know who is more vulnerable. So, and this is what you are try to answer with two different approach. So this is more a philosophical question in which direction we're going. Maybe Blanca, you want to start since you present first?
Yeah. I think it's a very interesting question. I when I reflect upon the results, I feel I often fall under these doubts, or like how about aggregated methods and results and the translation of them. I think it's two sides of the coin. There's pros and cons, as you were saying, and I think that it's complementary with the individual level data. I think that both of them are necessary in this sense. I think that maybe the main con of using aggregated level data is the fact of being careful of not falling into ecological fallacies of assessing regions and countries, but without obviously having individual data that you could somehow fall under conclusions that do not represent the individual level data. However, I feel that the high quality data that we have can somehow save that, because it's true that we have factors, unfortunately, that we only have in the national level, so not zero. But for instance, deprivation, which is one of the main results as well, or stronger findings, is in the NATS2 level. So it's somehow good concrete data in this sense in a supranational level. So that can still give us quite a bit of information. And I think that the good thing of aggregated level data is the policy intervention potential that this data has, in a sense, and this is also something that we're working on quite a bit at IS Global, how we can help policymakers to make decisions based on the data that we have. And for instance, here at Barcelona, we have a lot of studies based on Barcelona level data and how we can help local authorities to adapt the adaptation and mitigation strategies based on this data. In a European level as well, we know how subregionals are working, so that could also be potential information and evidence that we could provide to decision-making bodies. So I think that the fact of having so much data of such a big territory, let's say in this case Europe, does help to have a bit of an idea of where to start from. For instance, deprivation and inequality or education, these results already show where to start with when it comes to policymaking, and as well then going somehow down on the level and then ending up perhaps with like studies that Isabel has, right, in an individual level data. So yeah, how these two are complementary in that sense. I feel like that's something that we can reflect upon as well as academics. But yeah, I don't know if Isabel, you have a bit of a.
Oh, I definitely think the same. I think actually, like you need to start with the more like higher level data. I feel like to like guide you in what kind of things are interesting to study at the individual level. And I do get, like, for example, this very detailed, of course, ideally you have extremely detailed level for every person. And like also, because I mean, my data also has a lot of limitations. For example, you still don't know if people are actually exposed to the temperature that it's linked to, for example, stuff like that. So ideally you have perfect data for every person at every minute. But of course, like the problem with that is that we need to store that data. We need to do computational need to do computations using that data analyses. And I think we're only scratching the surface for that. So in the future, yes, definitely very cool, a lot of opportunities there. But like I already noticed with my analysis here that we run into a lot of problems where where I cannot use the full data because it's just too much for a server to use. So yes, it's definitely something very cool in the future, but I think definitely right now to get robust conclusions, this more aggregated level is definitely like leading in policy making, like you said, Blanca, I think. And it also makes it easier more inclusive for countries that might not have detailed data to also study the impact of temperature there. I think. And I think but also I think you had another thing that I think the like more aggregated level would, I think it would bias results towards the null. So if you find a significant result, like I think it's very likely that it is one, but I don't know if that's true. But
I don't have an answer to that question. This is why I was asking.
But I think, but that's what my that feels like intuitive, but I don't know if it is.
Because what I learned from from environmental epidemiology running this type of data, that what usually is the normal rule of thumb that we have from modern epidemiology handbook. Sometimes for this type of model, this doesn't work. So, I let the question to all the people here. There was a question from Azim. Maybe Azim want to introduce and was asking, have you considered the population status in the area and why the regression is used? So maybe you, Azim, want to add something on the question? Maybe Blanca or Isabel, do you want to explain how the difference in population has been taken into account, and maybe the concept of regression? I don't know what was the question about regression. The name regression derived from regression to the mean, and all the model that we use, we try to model a relationship between an exposure and an outcome, and we use different model that we call regression. Yeah. They are asking about the population status in different specific area.
I don't know, like population status, you mean density, population density, or something like that. For instance, when it comes to population density, we assessed that. It's just that the data that we have is I wouldn't say it's not the greatest. It's good data. It's just that we have an overrepresentation of, for instance, Paris, London, very populated areas that somehow drive the association. We also assessed it in the models, and it was not significant based on the different indicators that we had. So we consider that, but we believe that also with the different factors that we had in our study concretely, it's something that we somehow assessed as well with other indicators that would somehow give you a better understanding of the population status.
If there are no other questions, I think we are at the end.
Excuse me, ma'am.
Yes?
This is Asim.
Yeah, hello, Azim.
Hello, hi, ma'am. Ma'am, I want to know that the specific area. First of all, sorry for late joining. The ma'am or the study picked the data from a particular area. Okay. So my question is that let's say ma'am's data is from London. So in London, the people are from diverse regions. So let's say some people are from Asia, some are from European countries, and some are from UK. So the Asians, from the Asian region, the people are not used to, or they are more used to, let's say, 17 degrees centigrade or even to 30 degrees centigrade. So their temperature will not affect that much. But as compared to the Asians, like the European countries, they are even more prone to the 17 degrees centigrade or 20 degrees centigrade. So how can you manage that difference regarding the specific population?
Maybe I can try to answer this question. First of all, this is a very interesting question, and it's extremely complex to study because we are not only discussing about adaptation to temperature, but we are discussing about temperature acclimatization. There are probably some genetic factors. There are probably factors related to acclimatization and when the time of migration that is very complex to study. Also, Sweden that have several registers. We have a colleague here at Karolinska working with migration topic. It's very difficult to know when people migrated to Sweden because you have the person number, so you know when people has been registered, but you don't really know when people arrived. So you cannot take into account the time to migration. In Isabel work, we start to use ethnic groups, but this doesn't give us an idea about the migration component because there might be behavior factor, migration component. England also has lots of colonies in the past. So this is increasing the level of complexity. I don't have an answer how to study this. I think this should be probably studied in using data set that allowed also to study genetic vulnerability, looking in different countries. But it's very complex to look at this. Also because when we think about the African continent, it's so much the genetic variability that there are probably some genetic polymorphism that are more protective than others. And it's very difficult to study this when we are pulling everything together. But I totally agree, this is a very key question, and we'll probably be able, with these models, to adjust for it, but not to really properly study it. And Isabel is one of the first work where we are able to stratify for ethnic group, because this has not been done before.
Yeah, and even that is difficult because I can only do it in these three very broad groups. There is also ethnicity data, ethnic group data in our environment that is more detailed, for example, but that would make the groups too small to be able to run these sort of analysis. So you can't even when some of the more detailed data is there, we can't use it yet because it's just too small number of people.
And with this, we are 1 minute out of time. I really thank you, everybody, for joining today. And I thank so much Blanca and Isabel for presenting their studies. This is very interesting. I hope that we need to produce knowledge and also to communicate it. And really good luck with your PhD. And thank you so much for sharing this knowledge with us. And also to Eduardo for co-moderating the meeting with me, and Murat for organizing all of this. Thank you on behalf of our department and the Swedish Center of Impact of Climate Change. Bye-bye. Thank you.
Thank you.
Thank you.